there's a lot of work going on regionally to deliver on that. And good news, Nicola, is on the small working group across the 5 DHBs that are charged with enabling that. I wouldn't say lead because we're all leaders in that work, but enabling that work to occur.
Well, that's reasonably significant if we're the first to receive an equity plan.
Yeah.
Approach.
Yeah.
It's well worth of note.
Excuse me, Chair, we're now live on.
Okay. No more holding my World Wide Web. We're up to items 5.1 and 5.2 for those following live on the World correspondence from the Minister of Health. Okay, no other board comments. Anyone, Meredith or Rob, any? 6.1, the performance dashboard. Jim.
Yes. Just highlighting again, I think that we had quite a bit of discussion, I think was it Hauora or Tairāwhiti last week around immunisation and the additional effort that's having to go in to try and recover that after the COVID effect of people being extremely careful with their children, right. As could be and completely understood. But now the need to get kids out and get them immunised or get them via the outreach immunisation program, and the fact that it does recover by the time you get up to age 2 years, but that we would much prefer, of course, for that protection to be available for kids at an earlier age than that. Those newborn enrolment numbers there haven't improved, although I have seen some data just yesterday that is improving, so they'll start to flow through there. There's a piece of work going on with the general practices there around that. Some of that is actually turns out to be just reporting and will improve from that point of view.
Right.
Yeah, some of those ones you've asked for about screening was still to come on, but we do know that already in the bowel screening program, we are getting people through who have been screened within the community and now need colonoscopies. So that program is working.
And when are we expecting to get the sort of KPI tracking up and running on that?
I would say probably around about 6 months, because just need to get enough people out there and then to be able to see what the returns look like. At the moment, we've only had a month of people getting their test kits, and also it's
Certainly checked to Roger Faber last week, and he said it's been really, really positive. He's had at least 4 guys contact him who instigated a checkup with him, but because of him, and 2 of those had advanced cancer issues. So he was pretty happy with his role. Hey, Jim.
Yeah, I think we just need to add to that. If you've got frank symptoms of bowel cancer, don't wait for your test kit. Yeah, you get symptoms from bowel cancer mostly, so that's when you need to respond. Don't wait for a test kit, because you'll be waiting a long time.
Jim, on those immunisation stats, there's some commentary on page 25. I don't know whether to address it now or not, but since you talked about it, so you talked about the outreach immunisation service back to normal but overloaded, and you talk in that report about a lot of negative information towards vaccines. So obviously there's quite a bit of a barrier that we're hitting, and that's noted as a factor in reduced vaccination rates. So my note to the board was here, so what are we doing differently to combat that? Because it says the outreach immunisations back to normal, overloaded, most vulnerable families are declining and delaying OIS appointments. So what are we trying that's different to get around this?
It's a bit of a teamwork effort between an immunisation steering group met about Thursday or Friday last week. And I haven't heard the outcome of that, but I know that really it's all of the points of opportunity with families. So it's not just about there at the time of the immunisation. Clearly, it starts with during the pregnancy and with the care that's provided them by midwives around reinforcing the importance of immunisation at that point, and then reaching into well child tamariki Hauora services and the relationship that very quickly develops between the WCTO nurses and the families at that point, and just developing that relationship. So not necessarily sort of coming up hard on it, but just trying to work in that direction there, get the information out there.
It's a system of work that's been impacted. So your general practice teams, the outreach and immunisation service is really the last port of call for those families who've not responded to an alert by the general practice, or who haven't responded to an alert from well child. So they're hardest, they're the families that services have difficulty in attracting them into the service.
Right. So I've not seen any, I don't recall seeing any sort of feedback from those really first port midwives and other support people who go straight on newborns to say what barriers they're hitting. So that we get the stat that shows simply not getting immunised. Haven't seen anything to say what they're doing. I mean, are we confident that, for example, plunket nurses are tooled up to deal with a really hyped up anti-vaccine 5G? There's been a lot of cordial with the election with that crew that got 0.9% of the vote. Have they been given skills and updated, because they just might be hitting a wall and their toolkit doesn't have anything to deal with this? Are we confident that those people are actually getting support to address it? Because obviously if they're not making inroads, then we're not immunising children. The OIS is hitting the barriers. So are we sure that the very front end people have got the tools available to them to help whānau through this process?
I guess that's a really good question, because I'm thinking back now 2 years ago where VAX was the last challenge that this community had alongside the rest of the country. We know that our frontline workers are workers that have best engagement with whānau. And so their best equipment is to retain the trust of that whānau beyond this particular issue, whatever it is, ongoing until that child passes into other hands. It would be good to check in, because we haven't specifically done a check in on what tools are available for people to move. It's very, very difficult, as you will know, to challenge whispers in the dark. Basically, there's not a lot of information sitting around that, and it being touted as fact. So it's quite hard to challenge in that space. What I do know is that the teams who do understand what the evidence is use that information gently with whānau who are in that space. So I know that those that they use all of their capability to try to support whānau to make the right decision. Now it might be that that has affected 2 years old. It might be that has affected 5 years old. But in that moment when they're in that time with the whānau, when they're doing the check, what they're doing is looking after the child first to ensure that the child's milestones are being met if you're well child provider. And then they're trying to work more broadly with the whānau overall. So they're going to be looking at what's most important for the child as a point of contact to make sure that their milestones are being met, and that the immunisation becomes a conversation they have with those whānau in an ongoing way. We will check to see what the key areas of challenge have been with those particular providers.
I think this current environment would be really interesting.
I was going to say, I wanted to jump on after you had spoken, working on the ground, like when we were doing our hapu wānanga, and around that time, that was when the Samoan incidences were happening, and a lot of the parents were just very hesitant, cautious, and were holding back. And then once that was addressed and actually discussed out in open and shared the presenter shared the actual stats of what was happening in Samoa, gave the evidence, gave the information, and then the parents were able to feel like they were making an informed decision. And so I think some of the rumours or things that are going around on social media need to be addressed or discussed, and I guess debunked some of the myths that are going around. But and those discussions need to happen with the whānau in a balanced discussion, so that they feel like they're getting a balanced information. And a lot of the parents after the presentation felt a lot more confident in the decision they were making to immunise. So whether, my question was, are our midwives and blanket nurses equipped with the current evidence to share, or
Absolutely.
Yes, because
Absolutely.
Brown contacts, sends all the information through to the LMCs and the midwives. So any update goes straight to them. I mean, we offer women the flu and Boostrix vaccination, and we actually include that by saying this is your baby's first immunisation through you to your baby. So we try and promote it that way as well, and that's pretty much well accepted. But as somebody raised a point before, you have got to tread carefully. For an example, with a woman, and you'll see the smoking stats, we've still got the worst smoking stats for Hapu Mama nationally, really. And we try really hard on this, and we're progressing with a group at the moment that I've pushed for to try and make some changes. But the feedback I get from the LMCs, and it's realistic feedback, is that if they really push these women to, we really need to support you, we need to do this referral, we need to support you to quit and stuff, they sack the midwife. They don't want to hear that. So then they're actually, and the way the LMC system is at the moment, the sack the midwife, they're in groups. So that means they don't have an LMC. And they come under our jurisdiction then, and therefore they're missing a whole chunk of antenatal care, because a health professional's been doing what they should be doing and trying to encourage and support. But if you've got somebody that's adamant that is not for them, and this could be smoking or immunisation, the harder you push, the less they will be in contact with the health services. So therefore they have they miss out on other health opportunities. So we have got to be careful. And I don't think there's any health professional out there that isn't mindful of immunisation and stop smoking, quit smoking is highly important, particularly, from midwives going through to, the well child services and that. I mean, if we could improve this, just think about the reduction in admissions into the hospital, the reductions of admissions into maternity. So I don't think there's anybody, but I do think, it's like having the skills to put that across,
delivering it in a way that is well received. There's an art to that.
Yeah, and midwives have a really good ability to build rapport with a woman very, very quickly, and you have to in this role because it's a short window of opportunity. But we will have women that go, I've sacked my midwife, and you usually find out it's because that midwife has been vigilant trying to support them to meet the health requirements that will make their life and their baby's life a lot better, but they resist. So we've got to be realistic about this on how hard we do push, because otherwise we're compromising women and their babies, and that goes into the well child services as well. And I think you said that really well before. So anyway, just what to say.
So some of the programs that we are engaged in are looking at the whole wellbeing of mum and baby from pre-birth through to the child being handed over into schools. And so some of those things, Tairāwhiti have instigated a legacy program where their mums are engaged early. They're engaged in programs of promotion, health promotion, but it's not in a down your throat way. It's in a series of programs that they engage with those mums in to look at whole wellbeing, whole whānau wellbeing. And those things include what the important things are for that child to have in their journey. Now, those are things that we're trying to rebuild. When we were children, we had grandparents and parents. who would support whole whānau. These days we don't have the luxury sometimes of that occurring. And so what these programs are trying to do are instill a sense of legacy into young mums who will then be able to pass that information on as well. And one of those is Hauora, which is the support for safe sleep, which then becomes part of a Tairāwhiti legacy that goes forward. So those are some of the programs that are building around how we support children to thrive. It's very difficult for our frontline staff to be told no to something they know is really important for that child's future. And they will try everything they can to retain the relationship while building the confidence with mum and the whānau through that journey.
I know a few years ago there was frontline people, I don't know if they were specifically staff, but they were actually anti-vax, and they were tasked with dealing with newborns and things like that. So if we had that situation now, what could we do about it if it was staff that were out there with that message?
So if they're employed within the District Health Board, we would be ensuring that they're identified and a discussion with them would occur about whether they're in the space as a employed public health servant to be delivering the messages that we would want them to be delivered. In the community, if we are alerted to anything occurring in our community, we would generally be in touch with their organisation to have a chat.
Cool.
We accept an agreement.
Yeah.
Just conscious, we've got a couple of questions online there too, so might jump to Rob's and then Meredith's. Not sure if they've been answered in the corridor, Robin, but your question about the whether this is part of the equity plan, I think.
Yeah, yeah, just following on from Nicola's corridor, I just wondered whether this is really about looking at different triggers and, you know, no disrespect to the health professionals, but perhaps this is an issue about the messengers, about trying to get influence culturally and using a different platform to get the message across. So I think that's something that, I think that's what you were talking about, Nicola, but yeah, just an idea if this is an area that we need to look at addressing inequities, because I myself, I don't know of any active vaccine groups, but I could be completely, anti-vaccine groups. But perhaps we need to ask ourselves these questions. What Andy just brought up, do they exist? Because I got a 2-year-old.
They're all over social media.
And you'd be amazed at the idiots that are involved in it. People who think are right-minded, sensible people. Totally bought into this cope-up, and like you said, it's like this voice in the night. It's this insidious messaging. You can't front it and say, and it's a new thing. And that's why I'm wondering, do our frontline LMCs actually have an up-to-date toolkit to deal with things, because it's a now issue. Yeah. And on the back of Billy T's whole election thing.
On Billy T, but it was a now then.
Yeah, it was. But now it's become like we question authority, we question 5G, we question everything. You know, we question COVID as a pandemic. So it's a will now, and I can imagine people going, oh, I'm not so sure about that because I read on social media. So we may not have people skilled up to deal with it right now.
There was some work done, in countries where to battle it, where key leaders in government came out and basically challenged it, but in a way that was really fun, in a way that they minimise the impact of the negative messages by making the discussion around battling it not really about the battle, but about other things that drew communities forward. Mm-hmm. I mean, we probably need to think about how other parts of our system are also messaging.
The counter view. Meredith, does this corridor answer your partai?
Well, yeah, it does. I mean, the fact that we're having this discussion even is fantastic, because you're right. We're looking at a government who's looking to pursue a COVID vaccination, in respect to ongoing research and indicators. So I think I just wanted to ask, what are our actions, and have we got any jurisdiction to say to those groups, it's unhelpful what you're sharing, etc. I just wanted to know whether we have a stand against, is it negative information but is it incorrect? So how do we manage that role as a TDH when we know we have significant inequity issues in our region, and so we just don't need any more, I guess, adversity in this space. So, but what can we actually do if the information is just unhelpful, but it's correct to someone? I'm not sure where does this sit. You know, can we send a letter through to be our new health minister and ask what can be done in communities that tend to get targeted in respect to this issue? And yeah, where do we stand in an action space was my kind of the next steps to what can we actually do. Kia ora.
I think that's the thing, though. It isn't like a sort of like a mass advertising campaign. I don't think that is the way to go. I think it is those relationships that are developed between health professionals and families. That are the key things. And you know, as we know in Tairāwhiti, we've got now over 50% of the population enrolled with our Hauora well child Tairāwhiti order providers. So families are moving, in that direction themselves. And now the Ministry of Health is actually supporting us with that as well. So that's those ways of working that are holistic, not just about well child Tairāwhiti order, but the whole services that those providers are able to provide, and that's about trust and relationships. And I think that's the way to go.
Is that one of the issues though, Jim, is that we're still in a space where we still provide good information and ensure that the families can make a well-informed decision respecting their wishes should they choose not to vaccinate. So we still promote it at the absolute, it's the best, in respect to protection and all of that, but we still have an out clause to it's a parent's right to choose not to. So the messaging is really, be it hit or miss to whoever you're speaking with at the time into that relationship, isn't it?
Well, I'd suggest that our message is absolutely that immunisation is the best protection you can offer your child, and that actually the out is not provided, but that families can make a choice. And we don't actively say, look, take it or not. We're actually recommending that immunisation is an activity that's really beneficial. And so while it might seem like an out is there, I've observed families who've said, absolutely no, I'm not going to have my child immunised. I might think about it when they're a bit older. And they're not going to move from that. And that's not because they've been influenced by facts or they've been influenced by the latest discussion. It's a decision they've come to, knowing what the odds are. But also because, some of it's about understanding who immunisation. The child doesn't need to get this jab if everyone else is going to get it.
Sure.
Those are some of the things that are influencing.
And just remember again, the issue here is delay. It's not, there's a proportion of people who do not want to have their children vaccinated. But the main issue here is delay.
Can I ask, are we tracking like the rate of injuries from immunisations and whether those are increasing and whether that's a factor?
What do you mean injuries?
Injuries from a vaccination.
Adverse outcome, adverse
My son
reaction.
had seizures after his vaccination, so is there an increase in those that are happening? Or?
Yes, they're tracked and they're all reported, and I don't have the data, but I'm reasonably confident there isn't any increase in those.
Hickey's got a...
Oh, I know this is the next discussion.
Okay.
So personally, for me, I'd like, from an action perspective, to actually get an understanding of some frontline barriers that are being hit right now by LMCs, and just see if there's anything notably that's come out in the more recent environment. Because, we talk about picking up in the long term, but...
You keep saying LMCs. We don't immunise babies.
Oh, okay. Okay,
so
sorry.
It's well found.
Midwives...
So
it's actually
general
practice.
practice.
Yeah.
Okay.
Your OIS service is only called in when their child and their whānau have failed to come back after 3 trials.
Right. But the well child Tairāwhiti order services are in there because the care is transferred between the LMC to well child Tairāwhiti order between 4 to 6 weeks after birth, and so that's when that relationship develops there, and the first immunisations are at 6 weeks. So the LMCs are an important part in terms of the whole process.
Provide them with the information they recommend, but then the well child takes over, and we register all babies with the immunisation register, so they get the appointment through. So we do everything possible that we can, but we can't be accountable for the fact that they're then not having the immunisation, because we try our best, our absolute best.
So the actual first immunisations occur at that sexual check that baby gets and mum in general practice. And so the general practices take particular care to try and make sure that happens. But if it doesn't, the well child support providers are also there supporting that to occur. In some cases, actually helping people to get to general practice to have that occur. But of late, people haven't wanted to go to general practice because that's where people are who may be unwell. And I don't want to take my baby. So
if you look at the newborn enrolment with general practitioners at 6 weeks, 41% for married.
Yes, but we know that that's not necessarily correct. So that's just we just had that.
But there is a problem, because we've looked at that. We have been looking at that with well child and what we do in maternity, to make sure. I mean, I have my receptionist who asks every woman, and she rings the GP practice to make sure they're still registered, because some women don't know, if you don't actually go to the GP within a 2-year period, you signed off. You're no longer with them. They don't, give you a warning of that. So we've done that, and actually all the women were still registered with the GP. We checked the details prior to them going home, but you still get women that don't go. And we were looking at, is it because they've got bills there because they haven't paid bills for previously going, and they don't want to go in because there'll be, you need to pay this. But apparently that's not one of the problems we've looked into that. So
we've been working quite hard with general practice teams here under clinical practices to increase the responsiveness to Māori whānau who may not have attended general practice. So in this year, they've decided they will be looking at how do they increase access for those Māori whānau who may be enrolled but haven't attended. And so some of those things are underway. They will include where newborns are part of that whānau picture.
Is the conscious of time, and while this is an incredibly critical period of life and a valuable conversation, is the action here a follow-up to get an understanding of whether the frontline staff have those tools, and then to understand the newborn enrolments? Jim, you're saying those you think those statistics are. So a bit of a report next month on a check back on whether the tools and conversations the frontline staff have got the right tools, and then to also get an update on this newborn enrolment and just see where that lands us.
We'll get that from the immunisation steering group.
Well, there's also, if you're wanting to check in on a global level with the people who are giving the shots, that's generally in general practice. So we can ask general practice teams. Now, I'd be really surprised if our general practice teams were not equipped to respond to this. They, like everyone else, want that relationship to be a solid relationship to bring whānau back when they need support. So we'll, happily do the check. It might just be.
But it is at that point, mum and baby, they're getting their jab, aren't they? So the message has already succeeded. It's the ones that aren't getting there.
Sure. Yeah. That's where
how do you reach them? So doing a frontline check with general practice may not be.
The GP's got the frontline technology and
which then leaves providers who are not invested with doing the immunisations. And probably our check would be what have you heard from your families?
Right.
So it'll be a whānau voice story that you probably hear, and I know if we could maybe drop that into the December meeting.
Yeah.
Yep. Okay. Yeah.
So I know the newborn enrolment in general practice, that trend is heading in the right direction again. So I would hope that that's going to
come right, and we have
Jim,
do that in December at the same time.
The dashboard shows a 12-month immunisation thing heading downwards, but how does it look over a 3 year, say, page 17? I mean, is that where do we normally sit over the long term with Māori 8-month immunisations?
That has gone down over a period of that, probably that 3-year period. We've had the whole anti-vax video campaign, we had the tragedy in Samoa, and now we've had COVID. So all of those 3 factors are really the ones that have seen a steady decline in that over that period of time.
And this is a national picture
Okay.
as well.
Right.
Yeah, immunisation's dropping in all regions, isn't it?
Mm-hmm.
Okay, that was a useful discussion. Yes,
On page 18,
18.
surgical events, is it possible to get percentages rather than the numbers, just to get a better picture?
Mm-hmm.
Total surgeries.
Total surgeries.
The surgical events, percentages
Oh, yes.
for those, please.
Total
So in the
surgical events, yeah.
access to planned surgery, Māori is 82, total population is 27, monthly target is greater than 75, greater than 206. If you put it as a percentage, it's 36%. So for me, the percentages give a better picture.
Yeah. Remember though,
unless there's more to the discussion.
Well, there is, because planned surgery tends to be around procedures that are related to older people in the population. So you can't look at 36% as being the proportion of Māori in that. So we give you the proportion, you know what I mean? So what I'm saying there is that the percentage that you got from that wouldn't necessarily mean a lot until you looked at if you're trying to look at that as a percentage of population who are Māori, you need to look at what is for that group of people that are having that, what is the percentage of population who are Māori?
And so access to planned surgery, is it the figures there limited to the elderly or the total Māori population?
The total population. But the profile of surgery within the population tends to increase as people get older, because a lot of the procedures are around rectifying problems of life, hip joints, knee joints, hysterectomies, you name it. So that's, so the proportion of Māori within the population, as we know, declines as you get older. So we can provide you with a percentage, but to make it useful, we would need to provide you with what, for that group of people that have had surgery, what is the proportion of Māori within that?
That would be good. Thank you.
Okay, I'm conscious there's a couple of questions there, Meredith. I wonder if we could, as part of coming back in December, pick up an understanding of the adverse reactions to immunisation. The earlier question Amy raised, Jim, just board could get a sense of that as part of that December check back.
Yeah.
And that would answer sort of your 2 questions as part of that. Rob and Meredith, would that catch the point? Thank you. Yeah, and I think are you online? No, my haramai na. I think that's you.
That's the probation number.
You have a registered number, yeah.
Morena.
Kia ora, morena.
Kia ora, kia ora, everyone.
Any other questions on the performance dashboard before
Just
we?
The ASH numbers.
Yes.
Which
page are you on, Amy?
Bottom of page 17.
Bottom of page 17, the ASH numbers.
I mean, when you look at the target and how far off we are, high.
Yes, it's going to be one of those COVID positive things that is actually going to improve remarkably as that COVID effect starts to come through. And that's something that we need to hold on to as a positive out of the COVID experience.
That's good. Okay.
Meredith's got a hand up.
Oh, yes, Meredith.
It's just in respect to on the dashboard obesity, another topic that's been highlighted in a few media frameworks as well, understanding its complexities. And I just wanted to ask, what are we doing, TDH, in this region, I guess, in promoting and functions around programs, I guess, and promotion to address this, because this is part of that inequity speak. We talk often neighbourhoods where there are often high numbers of obesity are surrounded by dairies and outlet stores that sell cheap, sugary, bad food. And so I just wanted to ask, what are we doing? What have we got any planned? Or I bring it up because also I was made aware of the new crematorium that we are getting in this region is because they can't fit people in the current one due to obesity rates, so to speak. So I'm just the on-flow of impacts that lead into this space. So what's our plans in respect to obesity overall?
There was a group, Meredith, time goes by, it was last year or the year before, that was formed, and they went into the schools and did some publicity around with dairies and that about trying to sell more water or have water and actually prevent children having fizzy drinks in school. So I know that. Yeah, that's it. So I know there was that programme put in place, but I don't know whether that's still up and running. I'm not sure.
Yes, it is. So there's quite a significant program of healthy active living underway. You've received reports here about the new program. It's almost like a reverse of the previous HEHA program. So Tairāwhiti is so we've also got Healthy Families East Coast. That's a whole organisation that's dedicated to increasing awareness, knowledge and understanding of positive impacts of food and activity on growing healthy behaviours later in life. We have health promotion programs in general practice, which include support to engaging with healthy lifestyles. We have Sport Gisborne, who is our key provider of access to green scripts where people are referred in. We have ongoing approaches that look entirely at the promotional activity that supports healthy behaviours as people grow up. One of those is breastfeeding, just saying. And then there's a series of areas where people come into contact for the first time with understanding. The first point of contact you're referring to is the number of obese children that are picked up through before school checks. There's a series of activities that occur once you've hit that space, but then you also come to the attention within schools of people who need support and links into the public health nursing team. Then as you grow older and are able to take care of yourself more, you enter general practice. Again, in that space, there's lots of programs that support you to get onto a pathway that better supports. That does not speak to the innate social impacts of colonisation.
And just the obesogenic world we live in.
Yeah, and if I can add to that, I'm a trustee on Sport Gisborne, and it's a demonstration how multi-agency something like a guest is. I mean, there's incredible work happening. Even something like the Tairāwhiti Challenge at the moment, which has got over 2,000 people doing it. And I wouldn't be surprised if half of them were in the obese category, and they're really gaining benefits from that. So any of those initiatives, activity initiatives, are also helpful.
I think too, a big initiative, Meredith, at the moment is the Healthy Schools free lunches program by the ministry. I know firsthand, we have to stick to a really strict guideline of what the children can eat, and because we make 2,000 lunches a day. Hopefully it goes smoothly today for me. But within that program, we're seeing really positive changes in the children, and it's closing that gap of equity because all the children in the classroom are eating the same kind, and it's been really exciting to see children not eat any veggies and now are learning to eat new foods and new veggies that they wouldn't normally ever have eaten in their life. So I think that's a big initiative that the ministry are putting out to address obesity. Yeah, there's really strict guidelines on how much fat we can give and what type of foods.
It's an interesting one though, because I think you have to be a wee bit practical. You're up against very big business.
Absolutely.
And you know, Enviro Schools is a classic example. You know, we've drawn, you know, we heard about it in council, and it's a program that I've been involved in for a long time as well, where you're actually teaching people to grow their own and look after their environment in the same space. But and kids in particular just lap it up until they step out of that environment.
Yep.
And then the next thing that
back
hits
of your
them
buses
is sugar and in their teens, of course, you know, those of us with teenagers, it's alcohol and everything else is, you know, it's big business. So how do you tackle big business? Because that's what it comes down to at the end of the day.
I just wanted to, so I hear we are doing considerable work in this space, so kia ora, that's awesome. But we're seeing, I guess, the positive outcomes that Amy has just mentioned. So how do we qualify data to know that this region is becoming the smallest shrinking region in regards to obesity issues? Are we shrinking at a good rate? Are we, you know, losing pounds with our titirangi maunga walks? Because one of the things I do know, and I speak to people who are overweight and obese, etc., you know, they're whakamā. It's not an easy topic to talk about your body in a state of going into a medical clinician's room. You feel bad anyway. But how are we doing to get data to know that actually with all these activities that are being promoted, funded and whānau are changing, how would we know in this region that we are shrinking well and, you know, getting better outcomes? Do we collect that data? And I mean, the Titirangi Challenge, do people weigh themselves at the start and the end, all of that stuff? I'm just intrigued because, as I said, it's a topic that Judith Collins highlighted with Jerry standing behind her, holding everything in. But, you know, all of that. So I'm just intrigued about it.
I'm not sure quite how the health board answers that question in total, Meredith, but I wonder if...
What's our position on Judith Collins?
No comment. But what, Nicola, what insights can you give us from what Hauora Tairāwhiti understands of that?
So I
complete
mentioned
ecosystem question.
Yeah, it is, and it is an ecosystem question because you know, where it is sometimes it's really how long is a piece of string. Our indices talk about improvements against a range of different things that should tell us at the end of the day that those things are improved. If you're talking about a measure before and after a program, which could be 6 weeks, the measure is actually not whether you've lost weight. The measure is how long have you retained the information that then impacts on you in an ongoing way. That's a very difficult measure to come out with. So the hard data is how many deaths have we had as a result of those impacts of obesity, such as CVD, diabetes, and those range of things. And yes, we can look to that later in closed session. We'll be seeing some of that information. But the short answer is actually it's the long-term game. We have been colonised, and I'll say that absolutely, colonised by sugar for over 150 years. The more severe impacts are in our Pacific and Māori families, and we are still being impacted by that colonisation by the $1 sugars in the fizzy drink arena. And so our team actively encourages our DHB, and when I say our team, I mean our public health team, actively encourages our DHB to consider a number of those different things that have longer term outcomes. And I think the board will have quite a great influence over this over the next few years. If I can answer in that way, because the longer term measure is how many people are living longer in this area, as your higher indice to tell you that there are a number of things that have been underway for a few years that will now be showing over time. So if we can get our children on breast milk and staying on breast milk for 3 years, okay, we're going to fix it.
Thanks,
I'll
Nicola.
quickly jump in here.
Last question on.
I was going to say a good way to measure your obesity rate is looking at the sales of formula company and they're rising every year. Like they're pushing formula so hard, and they have projected targets for the next 3 years to double their sales. So that's a indicator in itself to predict our upcoming obesity rates.
So the other part of an ecosystem, of course, is the political piece. As DHBs, nationwide, do we have the capacity to inform back to decisions around sugar taxes and stuff
Yes,
like
we
that?
have on several occasions.
Okay, so that's,
This board has supported exactly that measure on several occasions.
Do we keep pushing? Is it is it a dead horse to keep flogging, or do we keep saying, come on, we need to keep bringing this back to the table?
I think it is important to keep bringing it back. I don't think there is a climate for it at the moment, but I think it is. Doesn't go away because I think the evidence shows that has proven useful in other countries. I think the argument has been up until recently that the countries that have introduced such measures, the evidence is still out, but I think the evidence is now being collected to show that that sort of a method does work. Yeah.
So you say the climate's not conducive right now? Is that because there's more important things, or
just wait a week? Still the government looks like let's talk about it again.
Right, conscious time here. Rob, you had one last question and then we might try and move on to the next agenda item, my second attempt.
Yeah, okay. I just want to talk, I want to go back to obesity. So I just wanted to understand what non-traditional ways are we actually using, and I'm talking about I'm back on data. What Meredith was asking is, rather than using deficit mode data collection and deaths and stuff, I'm interested to find out what are we actually doing to use non-traditional ways of collecting data. And I'm talking about things like, because don't get me wrong, because I try to take responsibility for my own health. I definitely know that there's more gyms that have been set up in town. Right, I drive around, there's more Māori gyms around, and I'm trying to work out, that seems to me to be a way in which we can use, and it's not the deficit, it's the strength-based approach. That's kind of what I'm looking at, is rather than looking at the negative of not doing something, what are we doing to focus on, so non-traditional ways of data collection and strength-based ways of actually accounting for changes in behaviour, health behaviour.
One of the biggest one we can comment on immediately is Te Huringa Pai, Robin, which is a program set up exactly in that format. It doesn't require a gym. What it requires is commitment from the individual in whānau to participate in an ongoing program that goes on beyond the 3 months or the 12 months process. It's a lifestyle and engagement process. And that, from our perspective, there are other gyms that have whānau strength-based as well. And the proliferation of those gyms, I think, has been sparked because of the approach that the leadership in those gyms are taking, which is whānau.
Yeah, so that's what I'm asking, is are we looking at, because I'm not actually sure if we're properly linked in with all of those gyms that are leading that. Does that make sense? So whether you've got a Te Huringa Pai, a TDH-led program, I actually don't really care who leads it. I just want to understand who's actually making a measurable difference in the lives of Māori health, if that makes sense. So I don't think we have to have complete ownership over it. We have to be doing everything. That's my 5 cents.
Yeah,
I think you're absolutely right as well. I think it's something that not necessarily Hauora Tairāwhiti is the architect or the drivers of that. We're not. It is Hauora, it is Tūranga Health. They've got an Eki2 program, which is around whānau-based activities, which gets people more active by doing things together. And that is, in many respects, that is actually similar to the Everest Challenge, in that you've got families. You will see whole families, and so that's sort of coming at it from many different angles.
Mm-hmm.
And the lifestyle changes. I mean, the biggest issue for us as a DHB is those non-communicable diseases that are a result of lifestyle. And you change lifestyle by looking at the dynamics around it and what are the factors involved in that. And those programs that are based around families and how they work together around an issue are the ones that are successful. Where gyms fit into that, gyms suit some people, but a lot of people they don't. So you've got to be more within that.
And so the other thing, just to finish this.
Yes, that's good.
Make it go
Okay,
away.
It's an important conversation, though. It's hard to just...
Well, Te Hurling of Paifits also engages with other Māori programs. So I'm Māori, a key leadership program that was established through weekend of street-based whānau engagement, and they now have kaumātua and mokopuna tamariki I'm Māori events. So it's not just...
I was just going to comment about I'm Māori and what a massive success that's been. It's growing a movement of health and wellbeing.
Yeah.
Just before we move on from the dashboard, the staff injuries of 0 doesn't match the SAC2 event on page 30. So someone's right data.
You have a look at that for us, Jim. Right, this time. 6.2 Chair's report, verbal update, and given Kim is an apology, I haven't got anything to relay, so hopefully that can get back on track slightly with that one. Nah.
Kia ora, everyone. Yes. I got a couple of points just to feed into the board, if I may. And I got some on Jim's report too. But anyway, just from the Te Waioro Nukutai Memeha where we had last week, full support for the dental services program going forward. Thank you very much. Lots of conversations around that. But essentially, love to see dental services be progressed up the, particularly up the coast. The youth funding EOI going out, that again, see very, very, very good support. One of our target audiences for Te Waioro Nukutai Memeha is the youth, so that is one feature we want to keep looking through. The mental health and addictions rebuild, if that's the right term, we had Owen and a couple of others attend our hui, and from our understanding, mana whenua have signed off on the site, and you can correct me if I'm wrong there, please, Jim or Nicola. We're very happy with that proposal. That process.
We're meeting today now at 12:30.
See, my prediction will be that will sign off. How about that? So in answer to a question raised by the board a while back about how does all of this work, resident iwi respect the role of mana whenua in this process. We understand once that's completed this afternoon, tomorrow, then we can fully engage with the rebuild process.
What?
Thanks,
all right. Cut it up. 6.4, Jim, your report.
Thank you. I'll just some of the sort of key points within that. So there was financial results. September was not one of our best ones. Quite a few factors within those. We canvassed those quite a lot at the FRAC meeting last week as well, but just to talk a little bit about that there, that we are utilising quite a lot of outsourced staff within the DHB at the moment for roster cover and for catching up. And while we are being successful in catching up in terms of planned care, we are also needing to maintain some coverage in some areas. Maternity would be a really good example at present around making sure we've got that roster covered there. We've also seen, I've just followed up the conversation last week with a bit more detail around an increase in the utilisation of management admin staff, just really what that is there. And top of page 20, I've just detailed some of the issues involved in that and the additional roles that we've got within the organisation, most of which are funded not completely in terms of that. So we also had some areas there of actual clinical supplies over expenditure, but and but actually our spend on cancer treatments is a little bit low at the moment, but we are expecting that will increase again as some of the people coming out of lockdown that are now coming back into the system in terms of cancer treatment will get that and catch up in that area as well. We are still seeing some reduction in admissions this year compared to last year, and in fact the last few years, which is a good trend to have, and we're wanting to try and cement that in. Already this afternoon, one of the topics on the agenda talking with primary care is about how we try and replicate that in coming years without the need for a lockdown. It has that kind of impact on our numbers of people coming into hospital. So I've got that on page 23. The acute admissions analysis over the last 9 years for those first 3 months of the years, and so first 3 months of the year, and you'll see that there's a good trend there, particularly impacted by that paediatric trend, which is the comment I made before around ambulatory sensitive hospitalisations. And you can also see on page 24, top of page 24, rebound in the numbers of people coming through in care this year as compared to the last few years, and also in terms of not just in numbers but in the actual amount of work delivery in terms of case weights of people coming through with that. We've already had a long conversation about immunisation, so I won't talk about that again. Planned care, I have mentioned the fact that we are coming up and improving on that. We have got some, just in terms of that, we put in a bid for some of the additional funding that is available around, we're getting just on $1 million for additional planned care this year that is in there, and then on top of that there was also some funding available around a number of project areas. We've been successful in 2 of those project areas that we put in bids in, which are around facilitating people through the system, which is one of the things we particularly wanted to do with an equity focus on that as well. So we've been successful in gaining those, in gaining that funding, and you can see there that while the numbers of people on our in our system waiting for certainty around their surgery is increasing, we're actually reducing the numbers of people who've been waiting longer than the 4-month period, and we're down to 55 now and are heading towards to get that back down to 0 again. That's a brilliant effort on behalf of our clinical teams in being able to do that. And the other area is around, that of particular note, is around first specialist assessments, and you can see in the graph on page 28 that we are also steadily working on getting that down. Have got back to pre-COVID levels of that now and are on a downhill trend on that again. That is taking quite a bit of work to be able to achieve that on a background of increasing numbers of people being referred into the system. But the team are fighting against that trend by ensuring people get through. Be mindful though that on that graph on the bottom of page 27 around staged and planned. So those are people that are within the system who are requiring a procedure but aren't in a fit state to have that procedure now and need some additional work up for that to occur. That the numbers of people in that category is also decreasing, and we'd really like to get that number down as low as we possibly can. And we won't get back onto the topic of obesity, but that would be a factor in that area as well. We're seeing less people in comparison to previous years coming through the emergency department. I do want to highlight there that just on page 30, the flight team, and they're doing really well at the moment in terms of their service and the milestone for them. We have just on page 31 there, oxygen supply and environmental issues. Government has made $35 million available nationally for improvements around oxygen supply within DHBs and some of the environment. So that's around negative pressure areas within hospitals for scenario planning for resurgence of COVID-19, were that to occur, or of course the long-term outlook for further pandemics in future years. There, we have been able to been successful in that, and Tony, I'm sure you've noticed the word oxygen spelled with a Z in it. Or more, yeah, that's, yeah, I just need to get that section of that.
Because I was wondering if that was another form of oxygen I wasn't familiar with. Aussie
a new improved version.
It's come from Australia, is it?
Yeah, so we've been successful in getting work done on we've got enough oxygen in our bulk store. We, with the flows that would be in place if we had 5 people ventilated and 50 people in hospital with COVID-19, the amount of oxygen that would be required to service the needs of that people, we'd have enough in the bulk store, but to get it through and vaporised, warmed up, to turn it from liquid to a gas, we need a new vaporizer that will handle that, and automatic de-icing equipment. And then some additional lines within the hospital to get in flow valves to get that to the right places. So we're going to get that work done. Craig, help me here. We're also going to get work done on some of the areas in the hospital that need additional piping of both oxygen and air, clean air, and a couple of areas around creating more negative pressure areas within the hospital. And so that was a good boost for us in terms of our capacity within the organisation.
So Jim, that was my question in relation to that sentence about the 12 DHBs, including Hauora, Tairāwhiti. My question was, what actually is the work being done? So you're saying new pipelines, vaporizer, de-icing machine. Can you double that up and make that icing machine available for drinks?
Well, yeah,
No.
it might have been in the past. If you just let it rip, it would create a lot of ice on the outside of the machines. It would have been okay for drinks, but we do want to avoid that because it makes the whole system.
Pretty sure you're only drinking water based on the last conversation anyway, Tony.
Oh yeah, no, I like my ice water. I love my ice water.
Jim, I'm trying to compute. We have historically been told when we've had financial losses, so red ink compared with budget, it's based on increased throughput, that the health needs, and for the first time we've seen reduction in throughput and volumes relating to some of the care, and yet we've got some of the worst monthly results we've ever seen. Are you saying that a lot of that is then due to catch up in planned care that got delayed? Is that, I'm trying to compute the reason we've had losses historically versus what we're now seeing in some of those ED and others where throughput is actually down for a bunch of reasons, and yet the financials still going in one direction.
Yeah,
I'm trying to.
Some in planned care, and you can see that planned care actually is up on prior years. So
yes.
some there,
Yep.
and some of that planned care is, I think we're at 200% on joints at the moment.
Yep.
So that's A, that's the start to do that. B, that's the actual prostheses that are being inserted to people. So that, remember too, the conversation we had around phasing around so that's another factor driving there. I think it's around about $850,000 effect on those first 3 months of the year as well. So yeah, there's a number of factors within there.
And are you saying there's some planned care associated additional revenue being negotiated with the ministry that you're expecting to arrive to offset some of this?
So we've got a sum of $970,000. We know exactly what that amount of money is. We just have to allocate it to where. So the work that we've actually done. So we know that roughly $250,000 is we have completed work of that nature already. So we just have to.
But is the revenue accrued in these numbers? No, that's
another $250,000 that's not accrued in those numbers as well.
Cool. Thank you.
So there's just a couple of factors involved.
Yes.
And then.
Are there any other questions on Jim's report?
Just in regards to page 28 around first specialist assessments, the meetings, I just want to note and acknowledge the 4-month waiting numbers are steadily dropping, even though the totals are kind of have increased and kind of are floating around that lower 2,000 number. I did want to ask, do we see that tracking downwards to be the trend over the next 6 to 12 months or something like that? And also, has there been any considered program or anything like that in order to be able to drop these total weighting of over 4 months in terms of FSAs?
Yeah, so the total weighting for an FSA will always be a number of a considerable size, given the number of people. So this is actually everybody that's being referred in over a period of time, over a number of months. So that is actually flattened off again now.
Yeah, no, I'm asking about
so
what's the result of the 4 month drop?
Yeah, the result of the 4 month drop is basically just getting more people through. So rebuilding our capacity again after that, and we do intend to keep on going in that direction, and that's the point of the additional funding that government's put up to assist us to be able to achieve that.
So this is a direct correlation to the government's additional funding and nothing that we've done internally, is that what you're saying?
No, it's a combination, but yeah, the additional money from the government on top is going to speed up the process. So we had a period of time, for instance, in orthopaedics where our capacity was much lower. We've got full capacity with orthopaedics now, hence the fact we're doing twice the amount of joint replacements that we plan to do at the moment. So that's freed up that capacity and enable us to do that. So that we have done that anyway, but then this additional funding that we're getting, plus the additional funding on top of that for these new roles to actually work with people and get them match fit basically, or help them get match fit faster, will actually enable us to get people through faster, but also particularly address those issues around equity that Nikki was talking about.
Additionally, I'm glad that you brought up orthopaedic stuff, because I did wonder too, like, are the reductions happening in one area and not in the other? Because, so that's what I was asking about the program of work maybe. So is there more reduction happening, say, in orthopaedics and no reduction happening in the other areas?
I think at the start of, so we've got those on page 26. Those specialties currently breaching maximum waiting time frames are the ones we are particularly focusing in on at present, and some of those are relatively, like I know just in general surgery, it's breaching SP5, which is the first specialist, which is the treatment one, is relatively easy to fix. Others are proving much more difficult around ophthalmology, otorhinolaryngology or ENT, and urology. So, but we have got some work that we're doing around how to fix those problems. And I know Anne's sitting in the back over there, and she's very much part of that as well in terms of fundamentally recruiting to be able to have the capacity within those areas.
Is the bigger chunk in ENT, or the bigger chunk in, was it definitely spread?
There's a large chunk in ENT, definitely. Of those people waiting for an FSA, there's a large chunk. We can provide that a split if you like.
Oh yeah, cool. Yeah, because this is the thing that the most people out in our community contact me about is just the waiting, and then they're kind of second guessing themselves, like, oh, have I missed the letter, and all this kind of stuff. And but I just do again want to acknowledge the fact that those numbers have reduced dramatically. We're smashing through those numbers. It's choice. It's great to be able to talk about how we can focus into specific areas now instead of going, oh man, there's all of these numbers, how are we going to get through these? So I do really want to commend South Jim and the team for bringing it down. Love to see this kind of continuing on.
So just following on from that, in that kind of space, and coming back to the positive reinforcement data, is it possible at all to see as a data set those coming off their wait list, as in, they've had their first specialist appointment, they've had their procedure, and they're effectively on their way into life again, tackling life head on again, as rather than just seeing those that are waiting and concerned about missing their letters and all that sort of thing. Is it possible to see, because I can't help feeling that in part of this, it's the fact that we don't actually have the specialist on site, so we can't, we're waiting for the Waikato who are probably dealing with their own backlogs, et cetera. Just so that we're starting to see numbers come through that are getting ticked off. It's a positive data set that offsets the build-up waiting for.
Mm-hmm.
There are probably a couple of answers to that question, which is a good question, thank you. The first is that all these waiting lists are managed using scoring tools to be sure that nationally we treat like acuity in a like way. And certainly you can look at this DHB and there's another measure, which is the standard intervention rates, which you would usually want to see at 1. However, our standard intervention rate, if I use hip joint replacements, is higher than the national standard, and it needs to be, because the amount of osteoarthritis in hips in this DHB is quite a bit higher than it is in a number of others. Similarly, the reverse is true. Knee joint replacements we do at a lower rate because we don't seem to have the degree of pathology that some other DHBs have. The next thing that would really help is for you to be able to see the workforce that's impacting on that total waiting list and the stratification of the waiting list compared to the national average. And if we use ORL as an example, we're in a really difficult transition at the moment. We're about to lose both our ORL surgeons. There are no New Zealand trained locums available to us. That's the nature of the workforce. So for us to be able to deliver that care, we have to recruit internationally. And in the current environment, we can't do that in less than 6 months at the moment. And we have to be really, really careful about how we do it, or we invest a lot of money and we don't end up with any outcome. The other thing that affects how you deliver against your waiting list is your OR utilisation. And there are lots of measures of operating room utilisation, traditionally spend 20% of a hospital's budget. And in our case, we don't quite have, and we won't have till the middle of next year, the complement of anaesthetists we need, and we don't necessarily have quite the right mixture of OR staff either. So we can't use our operating rooms as efficiently as we could. We're also dealing with quite a large acute volume, which will always have an impact on your elective service delivery, because your acutes have to be fixed first, if that makes sense.
Yeah. Yeah.
So there's a whole piece of planning that goes into whether you have the right workforce across various professional groups and how you manage your waiting list. And it's quite a lot more. If you only look at FSA time and time to intervention, we're not necessarily thinking as strategically as we should and using the tools that we should. But we're also building well towards getting those tools. So if we could get you even a straw man that looked a bit more detailed, then you would help to see the problem, if that makes sense, and start to give the guidance that you need to help us get to a place. And it's never going to be perfect. No DHB has it perfectly, but understanding your own population is the best way of dealing with it.
I guess also that I would add to that just what we can't influence. In other words, the workloads of specialists that are fly in, fly out effectively, or procedures that are done elsewhere, because we don't have the facility here. So that way we don't load ourselves up with, failure is not the right word, but lack of achievement based on something that we can't physically.
Absolutely.
Does that make sense?
But we also want to keep our own population, our own citizens, as close to home as possible.
Absolutely.
And if we send too much out, that paralyses it because sending out costs us money. That we can't then necessarily spend in the way we want to spend it here. So sending the right things in the right place is really important. Building the capacity to manage the right things here is also really important. And it allows us to attract the right staff. If we downgrade the services too much, then we can't get the people who will come run.
No, absolutely not. I'm absolutely not suggesting that.
No, I know you're not.
Not one iota.
It's juggling.
Yeah, it is. It's acknowledging the realities, I think,
Absolutely.
of the.
And making informed decisions on those realities, because otherwise we all keep beating ourselves, saying we're not doing it.
Exactly.
It would be useful to receive that sort of nuanced workforce to layers and how we're strategising. That would be a useful insight, I think, for the board in the next month or two.
Well, you did ask for that at the FRAC meeting.
Oh, did we?
You did ask.
Okay,
Yeah, something quite similar to that.
Okay, so a different question, similar answer. Right. I'm sure the question was different.
That'd be the case.
Yeah, there you go.
It really would be the case.
Yeah, well, yeah. So that, we were coming at it from the workforce development sort of aspect at FRAC, weren't we, Jim?
Yes, yeah, but it's a similar overlaps.
Yes, yeah, absolutely. Okay, I'm conscious of time. I'm wondering if there are any questions, other further questions on Jim reports, or whether we could maybe finish off Craig's and the board subcommittee reports before cuppa. How do people feel about that?
One quick question. Yep, that's a good idea. Page 31, mental health addiction services, second bullet point, the first contract deliverable is an implementation plan for delivery in 2021. Is that the plans for delivery in 2021, or we're going to come up with a plan?
Which page, sorry?
31. Johnson.
It's process of crime. Says new roles will be advertised in December to commence in January 2021. Does that answer your question?
Second bullet point, the first contract deliverable is an implementation plan for delivery in 2021.
Delivery of the service in 2021, not the plan in 2021.
Plan's got to be done this month.
Right, thank you. Sorry.
Cool.
That's when you got the bullet point.
Any other questions on Jim's report?
The bottom of page 32, Romero Fever, really concerned that the MOH is indicating that the swabbing program within general practice may not continue and would support any moves to say that this would not support our goal of eliminating rheumatic fever from Tairāwhiti. And good to know that we haven't had any cases.
Yeah.
I'm not sure because the minister indicating and then us thinking about what the response to that might be still to be ended. Okay.
So we'll
update you as soon as our team has had time to digest that in terms of what an alternative would be in terms of whether, in other places, swabbing was occurring in schools and all sorts of other places. We just need to work through, and it can be done through pharmacy at home.
Right. Yeah, good question, Steve. Any other questions on Jim's report? Okay. Craig.
Stuart, just a quick understanding from Jim's financial update, bottom of page 35. There's one table of the variance, Jim mentioned earlier around phasing. Of medical in the first couple of months of nursing personnel, about 320. Things to be reviewed. Standard specific role. Jumping up to page 38, there's a table in the comments in 39. It's moved into some outputs of some medical schemes. So you've got a net 280K adverse between medical personnel and outsourced medical. These sevens are available 864 on medical personnel and adverse on outsourced medical at 1.1 million. So the first one is ONG specialists. So the table on page 39 relates to some of the output we're doing. Period 3. this financial year versus last financial year. So we can see 1, 2, 3, 4, 5, 6 column. So FSA in 3 months, we had 144% increase, 3% increase in use seeing. Radiology physicians, 178 on prior year. Psychiatrists, 147.
Can you please speak up a little bit more, Craig? I can't quite hear.
We've only got one speaker at the which is
way down here.
Way down there. Other end of the room.
Speaker is coming. Here we go.
Cash is holding up well. Close of the month, we've got 8.7 million in the bank. And page 41, we've got our capital expenditure, which is well ahead of budget. Date 620,000, which is a good start. And the bulk of that would be the Morrissey Deer deferral from prior year into this current year. So good to see that's advancing and got a big move to continue that along with infrastructure and also clinical capital spend. Take any questions?
Not a question, just a comment on the bottom of page 38. Great to see that we've got our first ever psychiatry registrar starting to help with the long-term strategy, I suppose, and working through the work problems in there. Wonderful.
It's always been very difficult to recruit into.
Comment on that. It is a great achievement. That's a non-training registrar position. But as the team builds that team of psychiatrists and psychologists back, I think they want to get an accredited training position. And that's really excellent, I think. That's a tough week and they're having trouble filling their complement of staff. We have several other services that are looking to get vocational training accreditation, which in medicine is wonderful because we know it leads through to people who, if they won't come back to this district, are more likely to go back to more rural DHBs and not end up in the big metropolitan DHBs. So it's a really fantastic move.
Thanks, Anne. Any other questions on Craig's report?
Yep.
Meredith.
Oh, Meredith.
Yeah, I know I don't often ask a finance question, but I'm intrigued to know, if I was to look at our accounts, Craig, I was wanting to ask, like, how much is invested in young people, like our youth hub space I see in there. Thank you, Nicola, for all your mahi. I just was wondering if I was going to gauge our TDH, to look at what's investments we put into like our young people, youth, rangatahi kind of space. I mean, I appreciate your report doesn't go into that detailed as per service as such, but do we have that kind of data at hand? Like if I was going to say, in our region in this financial year, we spent this amount of money on specifically youth framed promotion program, health initiatives, etc., etc. Do we have that?
So Meredith, Hiwi Tarangi reviewed that exact information 2 months ago.
I was campaigning.
Yeah.
But they're available.
Could we recirculate that? Just was it something we could recirculate to Meredith now that she's back?
Thank you.
Thanks, Nicola. Back from the green. Yeah. Kapai, we don't have any board subcommittee reports this month, so people got I was wondering how long the refurbishment of the radiology would then be concluding the public part of the agenda.
Yeah. A minute.
A minute? Okay, there you go, board members. There's your challenge. A minute. You've got a minute for Papai. And
so many questions on this.
So this is, nothing on 7.1. So we're on 8.1, 45, refurbishment of the radiology department. Your questions are standing between you and a couple.
But no biscuits. If I'm not worth it.
So it's all part of the board approved capital program.
Yes.
It should have gone to Frank this month. It didn't. It's all been. This has been in train since I think the first plans were in 2012. Yeah. So we've come full circle and pretty much the plans look exactly as those ones in 2012. So it's just a board's approval, been over $150,000.
Hang on, sorry.
Presentation there for the major non-compliance and also the IANS report.
And the tender
And
price
the
against capital budget, so it is below the budget.
It's in line, so it's 317,000. It's a quote from Dawson's. It will be that we need to take out a couple of items being, because we didn't factor into that, the recovery consents and also the quality assurance debit, which is about 4,500. It's got a rough quote from GBG. Okay. But it will be all completed within that 317,590.
Any questions on that before we consider the recommendation? Tony's just raised the question whether this should be in public. Given
this shouldn't be in public. It's a contractual. It's got a. This would normally be captured by public excluded grounds, wouldn't it? Quote attached to it.
We've had these discussions a number of times over the years. The fact that it's here, is you can either have it either way. But we've had these conversations about whether we should be more transparent and accountable to the public and put them in public, or whether we should not. So it'd be good to get a view on that. But here it is at the moment.
Here it is at the moment, I'm sure.
Okay, so my questions are this: is looking at that quote, I couldn't identify any labour costs in there from that particular provider, and my question was more than one quote obtained, because it wasn't clear from the report.
Building and materials.
There was
Building and materials.
Yeah. So let's answer that in two parts.
Okay. Well,
yeah.
Okay,
so yes, surely labour and materials, and it was a closed tender of 3 providers were invited to tender. Only one did, and also building company.
Thank you.
So the others declined to quote at all?
That's right. Yeah.
Okay.
Which is often the case, and it's often the challenge that we face, and I think we are very fortunate to have the support and the relationship that we do with similar instances with the new medical day unit. There was only one tender for that, and that was awesome.
And that was successful. Okay, any other questions before we consider the recommendation? Okay, so the recommendation is that the board approves stages 1 and 2 refurbishment of the radiology department. All those in favour?
Aye.
Against? Carried.
Super, thank you.
Well done, thanks Craig. Thanks everyone. That brings us to the end of the public section. So we can, perhaps before we break this, someone like to move the resolution that after the break we move into the public excluded. Sandra, thank you. Someone present that. Thank you. All those in favour? Brilliant. I want to have a well-earned cup of tea and ka kite to those live on the World Wide Web, and 15 minutes. Rob, no, there it is. Cup